Hello friends, I am Dr. Nitin Nema, Assistant Professor at Department of Pharmacology, Sagar Institute of Pharmaceutical Sciences. Today we are going to learn about drugs acting on GIT tract, antacids, anti-secretory and anti-ulcer drugs. The topic is divided into 8 modules. Module 1 Introduction, Module 2 Pathogenesis, Module 3 Mucosal barrier, Module 4 acid pepsin secretion, Module 5 causes of peptic ulcer, Module 6 goal of treatment, Module 7 drugs used in peptic ulcer, Module 8 prevention of ulcer relapse and its complications. Peptic ulcer is a gastrointestinal disorder due to an imbalance between the aggressive factors like acid, pepsin, Helicobacter pylori and defensive factors like bicarbonate secretion, prostaglandins, gastric mucus, innate resistance of the mucosal cell factors. Normally, peptic ulcer develops when aggressive factors overcome the defensive factors. The major factors that disrupt the equilibrium between aggressive factors and defensive factors are Helicobacter pylori, acid pepsin hypersecretion, non-steroidal anti-inflammatory drugs, sometimes idiopathic due to usage of tobacco, psychological stress, rapid gastric emptying and Zollinger-Ellison syndrome, where there is a high and uncontrollable production of acid also lead to ulcer formation. Figure 1 Anatomic structure of the stomach and duodenum and most common locations of gastric and duodenal ulcers. Ulcer is any disruption in continuity of the mucosal integrity, generally more than 5 mm in size and deep, involving submucosal layer. Burning, epigastric pain exacerbated by fasting and improved with meals comprises of symptom complex which is known as peptic ulcer disease. These ulcers are of two types. First, duodenal ulcer, mainly caused by H. pylori, NSAIDs induced basal and nocturnal acid secretion increased and HCO3 decreased. Second, gastric ulcer, mainly caused by mucosal injury, basal and stimulated acid secretion decreased. Dyspepsia in its various forms has been mankind's companion since the advent of bad cooking, overindulgence and anxiety. For several decades, the dictum "no acid, no ulcer" has dominated the pharmacological basis of treatment of ulcer therapy and the drugs used. Reduced acid secretion. However, in 40 to 70% of patients of duodenal ulcer, acid secretion is within normal limits, whereas in gastric ulcer, acid secretion is either normal or below normal. Patients of Zollinger-Ellison syndrome, characterized by abnormally high acid secretion, show minimal incidence of peptic ulceration. It is therefore apparent that peptic ulceration is not solely induced by offensive acid and pepsin secretion. Breakdown of mucosal resistance, which constitute mucin bicarbonate secretion, phospholipids layer and tight junctions, cell proliferation, prostaglandins, epidermal growth factors, mucosal blood flow, etc., have got an important role to play in ulcerogenesis. Figure 1. In a broad sense, ulcers are thought to be due to an imbalance between aggressive and defensive mucosal factors. The treatment of peptic ulcer disease is thus directed towards strengthening the mucosal defensive factors rather reducing acid pepsin activity. The mucosal barrier consists mainly of mucus and bicarbonate secreted by neck cells of gastric glands and surface mucosal cells. Mucus is one of the nature perfections protecting the gastrointestinal tract from infective, chemical and physical insults. It has been commented that it encloses the gastric juice in the stomach as if it is an impermeable porcelain vase. Much of the bicarbonate is trapped in the mucus gel and both together help in maintaining the pH gradient of 1 to 2 at the luminal side and 6 to 7 at the surface of epithelial cells. Prostaglandins stimulate mucus and bicarbonate secretion and also increase the mucosal blood flow. Epithelial protection also involves through tight junctions that serve as a physical barrier through ion permeation and by virtue of rapid cell proliferation, cell restitution and surface active phospholipids layer. The duodenum is also protected by this mucosal barrier from the effect of hydrochloric acid. Figure 2, gastric mucosal barriers. The stomach secretes about 2500 ml of gastric juice per day, which consists mainly of hydrochloric acid and pepsinogen as the principal gastric secretory product. Hydrochloric acid is directly secreted in the lumen by the parietal cells, where hydrogen ion and chlorine ions combine to form hydrochloric acid. The other important cell type, the chief cells secrete pepsinogen, which is activated into pepsin in the acid medium below pH 4. Acidification of ingested food initiates the process of digestion by creating optimal conditions for peptic digestion of proteins. Stimulation of gastric secretion during digestive involves cephalic, gastric and intestinal phases which overlap in time and are modulated by complex neural and humoral interplay. At rest, parietal cells contain abundant tubovesicular structures with hydrogen potassium ATPase molecule within their walls. When stimulated, these tubovesicular structures move to the apical membrane and fuse, thus inserting many molecules hydrogen potassium ATPase into the membrane. These ATPase molecules are now exposed to potassium in extracellular fluid and hydrogen potassium exchange begins. Hydrogen potassium ATPase in apical membrane of the parietal cells pumps hydrogen ion against concentration gradient. Acid secretion is stimulated by histamine via H2 receptor parietal cells and by acetylcholine via M1 enterochromaffin like cell secreting histamine and M3 parietal cells receptor. Gastrin probably acts directly, although mainly through enterochromaffin like cells via G receptor. Prostaglandins, PGE and PGI2 on the other hand inhibit gastric acid secretion through stimulation of PG receptors. Histamine 2 receptor activate hydrogen potassium ATPase by generating cyclic AMP, while muscarinic and gastrin receptors appear to function through the phospholipase C, leading to mobilization of intracellular calcium. Prostaglandin decrease adenylate cyclase activity and reduce cyclic AMP level to inhibit acid secretion. Use of painkillers called non-steroidal anti-inflammatory drugs such as aspirin, naproxen, ibuprofen and many others available by prescription. Even safety coated aspirin and aspirin in powdered form can frequently cause ulcers. Excess acid production from gastrinomas, tumors of the acid producing cells of the stomach that increases acid output, Zollinger-Ellison syndrome, excessive drinking of alcohol, smoking or chewing tobacco, serious illness, radiation treatment to the area. First, relief of pain. Second, ulcer healing. Third, prevention of complications, bleeding, perforation. Fourth, prevention of relapse. Drug used in acid peptic disorder can be classified according to their mode or mechanism of action by neutralization of acid secretion, antacid, then systemic sodium bicarbonate, sodium citrate, non-systemic magnesium hydroxide, magnesium carbonate, magnesium trisilicate, aluminum hydroxide gel, megaldrate, calcium carbonate, miscellaneous category alginates, cymethicone. Second, by reduction of gastric acid secretion, H2 antihistaminics, cimetidine, ranitidine, famotidine, roxetidine, nizatidine, loxetidine, roxetidine. Next, proton pump inhibitors, omeprazole, pantoprazole, lansoprazole, esomeprazole, rabeprazole. Next, anticholinergics, pyranzapine, talenzapine, dicyclomine, propanthelene, oxyphenonium, doxapine, trimipramine. Next, prostaglandins, misoprostol, enprostil, rioprostil, erboprostil. Next, antigastrin, octreotide. Next category, mucosal protective defensive factor promoting agents, ulcer protectives, sucralfate, colloidal bismuth, subcitrate, ranitidine bismuth, subcitrate. Next, ulcer healing drugs, carbenoxolone, sodium diglyceride, licorice, anti-H. pylori agents, amoxicillin, clarithromycin, metronidazole, tinidazole, tetracycline, colloidal bismuth subcitrate and proton pump inhibitors combination. Antacids. Antacids are weak bases that neutralize gastric acid and raise pH of gastric contents. Optimum peptic activity between pH 2 to 4. The beneficial effect of antacids can also be due to their mucosal protecting actions such as stimulation of bicarbonate production, enhancement of prostaglandin synthesis or reduction of H. pylori colonization. The potency of antacids is determined by acid neutralizing capability, that is number of milliequivalent of hydrochloric acid that is brought to pH 3.5 in 15 minutes by unit dose of antacid preparation. Systemic antacids, NaHCO3 is water soluble, short acting and acts instantly. It is a potent neutralizer. pH may rise above 7, which can cause dramatic acid rebound phenomena, alkalosis and CO2 accumulation in stomach. Increased sodium ion load can cause water retention, so it is contraindicated in chronic cardiac failure patients. These can be used in patients of dyspepsia and can give symptomatic relief in peptic ulcer and reflux diseases. Non-systemic antacids, these are insoluble in water and are poorly absorbed, form chloride salt in stomach and in turn reacts with intestinal HCO3, so that there is no final acid base disturbance. Magnesium ion salt absorb water, stimulate cholecystokinin and thus promote laxative action. Aluminium ion salt polymerizes in itself and coats the ulcer crater, relaxes intestine, adsorb pepsin and pH more than 3 and activates it. Hypophosphatemia can cause osteomalacia and stone formation, so it is contraindicated in renal failure. Calcium carbonate is a potent neutralizer. The major drawback of calcium ion diffuses in GI mucosa, which causes direct stimulation of parietal cells for hydrochloric acid and gastrin secretion. There is rebound hyperacidity that increases the antacid requirement. In addition, it causes hypercalcemia, hypercalciuria, alkalosis and stones. So, these are contraindicated in renal failure. Antacid combinations preferable: fast magnesium ion and slow aluminium ion. Magnesium ion laxative and aluminium ion constipating. This can decrease the dose and toxicity of individual component. Milk alkali syndrome. Earlier, calcium carbonate was advocated with larger doses of milk that led to milk alkali syndrome, which comprises of headache, dizziness, anorexia, weakness and abdominal discomfort. Calcium deposits and renal stones. Administration: sufficient dose of antacid when given 1 hour after meal effectively neutralize gastric acid for 2 hours, and a second dose is given after 2 hours maintains the effect for over 4 hours after meals. Different doses of antacids are required depending upon their ANC. Uses: antacids are mainly used in treating GERD and relieving pain from episodes of heartburn and non-ulcer dyspepsia. They are also used as adjuvants with anti-secretory agents in treating ulcer dyspepsias. Anti-secretory drugs. Gastric secretion is under the control of 3 prominent secretagogues: histamine, acetylcholine and gastrin. However, the final common pathway is through the proton pump hydrogen potassium ATPase. H2 receptor antagonist. Cimetidine, ranitidine, famotidine and roxatidine, the 4 H2 antagonists are available in India. These drugs share structural homology with histamine, although each has different potencies, inhibiting all phases of gastric secretion, fasting and nocturnal as well as histamine and food stimulated acid secretion. They partially decrease gastrin and cholinergic stimulated acid secretion. Secretory responses to other stimuli like insulin and alcohol are also attenuated. Acid volume, pepsin content and intrinsic factor are reduced, but vitamin B12 absorption is not interfered with. They have got anti-ulceronogenic effect against gastric ulcers induced by stress and NSAIDs. All are absorbed orally, with famotidine having lowest bioavailability 40%, ranitidine 50%, cimetidine 80% and nizatidine having highest bioavailability more than 90%. Cimetidine undergoes first pass metabolism. Food does not affect their absorption. The relative potency varies from cimetidine to famotidine, with ranitidine and nizatidine having intermediate potency. Cimetidine can cross placenta and brain, while others have poor penetrability. Their T-half varies from 1.5 to 4 hours and duration of action varies from 6 to 12 hours, the highest being with famotidine. The common side effects mostly found with cimetidine are headache, dizziness, diarrhea, muscle pain when given as intravenous bolus. Cimetidine mainly causes bradycardia, arrhythmias and cardiac arrest. Fever, transient neutropenia and rashes are infrequent. Elevation of plasma aminotransferases can also occur. Cimetidine has got a prominent anti-androgenic effect. It produces reversible gynecomastia in males due to enhanced release of prolactin when given in high doses and for long duration. The major drug interactions of H2 blockers occur with antacids which decrease their absorption. Cimetidine inhibits cytochrome P450 which leads to inhibition of metabolism of phenytoin. Phenobarbital, sulfonyl urease, theophylline, metronidazole, warfarin, quinidine, lignocaine, nifedipine, etc. It also inhibits renal tubular secretion of procainamide and decreases absorption of ketoconazole. Cimetidine therefore is not commonly used because of low potency and many side effects and drug interactions with large number of drugs affecting their metabolism through inhibition of cytochrome P450 activity. The advantage of ranitidine over cimetidine is that it is 5 times more potent than cimetidine with minimal cytochrome P450 inhibition, permeability to cross blood-brain barrier and placental barrier and anti-androgenic activity. It has also got a longer duration of action than cimetidine. The newer cognizor famotidine and roxetidine have got much less side effects and are more potent. Suppression of nocturnal acid secretion appears to be the most important determinant of rate of healing of duodenal ulcer. Further, to prevent reoccurrence, half of the daily dose of H2 blocker can be given daily at bedtime. The initial recommended dosing profile of cimetidine is 400 mg by a day, ranitidine 300 mg, famotidine 40 mg and nizatidine 300 mg. These drugs are mainly used for duodenal gastric and stress ulcer, Zollinger-Ellison syndrome and gastric esophageal reflux disease. They can also be used as adjuvant in therapy of urticaria not responding properly with H1 blocker and as prophylactic to prevent aspiration pneumonia. Proton pump inhibitors, these are substituted benzimidazole derivatives that covalently bind and irreversibly inhibit hydrogen potassium ATPase. Both basal and stimulated acid secretion to various secretagogue is inhibited. They inhibit the final common step in gastric acid secretion dose dependently. Esomeprazole, the newer agent is racemic mixture. Omeprazole, lansoprazole and rabeprazole are available as enteric coated granules in sustained release capsule that dissolve within the small intestine at pH 6. Pantoprazole is also available in parenteral formulation. Omeprazole is a prodrug. It is degraded at low pH. It is absorbed in intestine and absorption is around 50% after oral administration. It is highly protein bound and T-half ranges from 1 to 2 hours. It is inactive at neutral pH, but its accumulation in an acidic environment in the gastric canaliculi activates it, probably by prolongation. Its inhibitory action on acid secretion improves its own relative bioavailability. At pH less than 5, cationic forms a sulfanic acid and a sulfonamide configurations that react covalently with the SH group of hydrogen potassium ATPs and inactivate it irreversibly. Adverse effects are relatively uncommon on short term use, while long term use may cause severe hypochlorhydria, which may favor bacterial overgrowth. Hypergastrinemia inducing gastric hyperplasia. They inhibit oxidation of certain drugs like diazepam, phenytoin, warfarin and increase their plasma levels. Newer proton pump inhibitors are developed either for their irreversible proton pump inhibitory activity or resistance to acid degradation on oral administration. Lansoprazole inhibition is partly reversible, while pantoprazole is more acid stable. Rabiprazole and esomeprazole seem to be better ulcer healers. The recommended dose profile is 20 to 40 mg per day for omeprazole, 30 to 60 mg per day for lansoprazole and 40 mg per day for pantoprazole. They are either given in two divided doses, first dose in the morning 1 hour before meal and second dose at bedtime or as a single full dose at bedtime for 4 to 6 weeks. However, as maintenance dose for prevention of remissions, the dose can be reduced to half at bedtime. Proton pump inhibitors are mainly used for Zollinger-Ellison syndrome, duodenal ulcer, GERD and H. pylori therapy. Anticholinergics. Pyrazipine is a relatively specific M1 receptor antagonist and acts at M1 receptor found in the intramural ganglia, histamine secreting cells and gastric parietal cells. It reduces basal and stimulated acid secretion at doses that have minimal effect on heart, eyes, bladder, etc. It is given orally and is equally effective as cimetidine in healing gastric and duodenal ulcer. Blockade of ganglionic receptors is also appears to underlie the ability of pyrazipine to inhibit relaxation of lower esophageal sphincter. It may produce unwanted effects like dry mouth and blurring of vision. Antigastrin. Octreotide is a long acting synthetic somatostatin analog and inhibit gastric and pancreatic secretion. It is reported to be effective against Zollinger-Ellison syndrome. Prostaglandin analogs. PGE2 and I2 inhibit acid secretion and promote mucus and HCO3 secretion. In addition, they have got cytoprotective action and reinforce the mucus layer by increasing phospholipids content of surface epithelium, mucosal repair and restitution and mucosal blood flow. These drugs combine with the PG receptor on the parietal cell and inhibit the action of cyclic AMP. Misoprostol 15-methyl PGE1 is rapidly absorbed, undergoes extensive first pass metabolism and is converted into active misoprostolic acid. It is approved by the US Food and Drug Administration for clinical use in the prevention of NSAID induced gastroduodenal mucosal injury. The standard therapeutic dose is 20 microgram 6 hourly for 2 to 3 weeks. The major adverse effect includes nausea, diarrhea, abdominal cramps and dysmenorrhea. Prostaglandins should be avoided in pregnancy as it can lead to abortion. Other synthetic prostaglandins used are enprostil, rioprostil and erboprostil. Ulcer protectives. Sucralfate is basic aluminum salt of sulfated sucrose. It polymerizes at pH 4, forming a gel which binds to proteins and glycoproteins in the ulcer crater and forms a protective coating which acts as a barrier to acid, pepsin and bile salts. It has no acid neutralizing property but absorbs pepsin and bile salts. It enhances cytoprotection by augmenting gastric mucosal prostaglandins synthesis. Sucralfate may also induce a trophic effect by binding EGF, stimulate mucus and HCO3 secretion and enhanced mucosal defense and repair. It is minimally absorbed by oral administration. The most common adverse effect is constipation 2 to 3% and hypophosphatemia. It should be avoided in chronic renal insufficiency to prevent aluminum induced neurotoxicity. Standard dosing is 1 gram 4 times a day. As sucralfate absorbs many drugs like digoxin, warfarin and tetracycline, so it should not be taken 2 hours after the consumption of these drugs. Colloidal bismuth subcitrate and tripotassium dicitro-bismuthate are the most widely used preparation of bismuth. It does not act as antacid but heals 60% ulcers at 3 to 4 weeks and 80 to 90% at 6 to 8 weeks of its daily treatment. They are reported to be effective against H. pylori and together with tetracyclines, metronidazole and anti-secretory drugs like proton pump inhibitors or H2 blocker therapy is reported to increase ulcer healing up to 90% and prevent gastric or duodenal ulcer relapse from 80% to nearly 10%. CBS combines with mucus at the ulcer base forming a glycoprotein bicomplex that coats the ulcer, absorbing pepsin, enhancing local PG synthesis and stimulating bicarbonate secretion. CBS is minimally absorbed after oral administration and whatever small amount is absorbed is excreted in the urine. Unwanted effects include nausea, vomiting, blackening of tongue and feces. Prolonged use can cause osteodystrophy, encephalopathy if renal excretion of bismuth is impaired. Dose 120 mg 6 hourly. Ulcer healing agents. Carbenoxolone and diglycerinated licorice are derivative of glyceric acid. A component of licorice roots are found to promote healing of gastric and duodenal ulcers by altering the composition and quantity of mucin. It is a steroid congener having aldosterone-like activity, increasing fluid retention and hypertension and hypokalemia. Concurrent administration of spironolactone, an aldosterone antagonist, controls fluid retention as well as abolishes the ulcer healing effect of carbenoxolone. Therefore, its use is very limited. Diglycerinated licorice seems to have less fluid retention property compared to carbenoxolone. Dose carbenoxolone 100 mg per 8 hour, DGL 400 mg per 6 hour. H. pylori regimens. H. pylori is a gram-negative rod residing in deeper portion of mucus gel between the mucus layer and epithelium. It is S-shaped having multiple flagella. In developing countries, 80% of population above the age of 20 may be affected. The colonization is influenced by domestic crowding, unsanitary condition, unclean food and water, exposure to gastric contents, and is transmitted by oral or fecal-oral route. The host factors like the duration and site of infection, the extent of inflammatory response and bacterial factors like structure, adhesions, porins and enzymes liberated govern the infectivity. H. pylori is generally associated with chronic active gastritis, duodenal ulcers, gastric adenocarcinoma and B cell lymphoma, but only 10 to 15% cause frank peptic ulcer. The treatment is not straightforward. Single antibiotic regimen is ineffective. Addition of proton pump inhibitor or H2 receptor antagonist enhances effectiveness of regimen, probably by altering acid environment and having direct inhibitory effect. At least 10 to 14 days of treatment is always better than short term treatment of few days. Documented eradication of H. pylori in patients with peptic ulcer disease is associated with dramatic decrease in ulcer, recurrence to 4% in gastric ulcer patient and 6% in duodenal ulcer patients, and may lead to diminished recurrence bleeding. Triple therapy, lansoprazole 30 mg BD or ranitidine 300 mg OD or bismuth subcitrate 120 mg QID plus any two of amoxicillin 500 mg TDS, clarithromycin 500 mg BD and metronidazole 400 mg QID or tinidazole 500 mg BD. Quadruple therapy, omeprazole 40 mg BD, tetracycline hydrochloride 500 mg QID, bismuth subcitrate 120 mg QID plus metronidazole 500 mg TDS. Following are the criteria which are important for the maintenance of ulcer therapy. First, frequent relapses. Second, severe and or prolonged pain with relapse. Third, previous hemorrhage or perforation. Fourth, other serious illness, cardiopulmonary disease. Fifth, age over 60 years or smoking etc. as risk factors. Sixth, large or deep duodenal ulcer at endoscopy. Seventh, need for NSAID with a known previous ulcer. Eighth, ulcer associated with NSAID medication. Various strategies to contain the remissions are advocated, which include continuous or on demand intermittently low doses of H2 blocker or proton pump inhibitor or sucralfate or antacids. However, the continuous maintenance with low doses of H2 blocker or proton pump inhibitor is most effective and convenient. Peptic ulcer disease, also known as peptic ulcer or stomach ulcer, is a break in the lining of the stomach, first part of the small intestine or occasionally the lower esophagus. Common causes include the bacteria Helicobacter pylori and non-steroidal anti-inflammatory drugs. Other less common causes include tobacco smoking, stress due to serious illness, Behçet's disease, Zollinger-Ellison syndrome, Crohn's disease and liver cirrhosis, among others. Older people are more sensitive to the ulcer causing effects of NSAIDs. The diagnosis is typically suspected due to the presenting symptom with confirmation by either endoscopy or barium swallowing. H. pylori can be diagnosed by testing the blood for antibodies, a urea breath test, testing the stool for signs of bacteria, or a biopsy of the stomach. Other conditions that produce similar symptoms include stomach cancer, coronary heart disease and inflammation of stomach lining or gallbladder. Diet does not play an important role in either causing or prevention of ulcers. Treatment includes stopping smoking, stopping NSAIDs, stopping alcohol and medications to decrease stomach acid. The medication used to decrease acid is usually either a proton pump inhibitor or an H2 blocker with 4 weeks of treatment initially recommended. Ulcers due to H. pylori are treated with a combination of medications such as amoxicillin, clarithromycin and a proton pump inhibitor. Antibiotic resistance is increasing and thus treatment may not always be effective. Bleeding ulcer may be treated by endoscopy with open surgery typically only used in cases which is not successful. Peptic ulcers will get worse if not treated. Treatment may include medicine to reduce stomach acids and antibiotics to kill H. pylori. Antacids and milk can't heal peptic ulcer. A person may need surgery if your ulcers don't heal. Thank you friends, hope you enjoyed today's lecture and hope to see you soon in the next one.